Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
My name is Adele Fielding and I am Professor of Haematology at UCL Cancer Institute, London, UK, and Chair of the UK National Cancer Research Institute Adult ALL Group. My speciality is acute lymphoblastic leukemia. I'm going to discuss the paper Intensified Therapy of Acute Lymphoblastic Leukemia in Adults, report of the randomized GRAL 2005 clinical trial. This work, carried out by the French Cooperative Group for Research in Adult ALL, evaluates the outcome of adding hyperfractionated cyclophosphamide, termed Hyper-C, a cornerstone of the commonly used adult hyper-CVAD regimen, to an already intensified, so-called pediatric-inspired standard of care therapy. The headline finding of this study is that in the primary intention-to-treat analysis involving 787 patients aged 18 to 59 years with both B and T precursor ALL, there was no difference between the two arms. Beneath this seemingly simple conclusion by randomized arms lies a wealth of interesting information, which I will discuss in detail in order to draw any implications for current clinical practice. First, let me explain in a little more detail how the patients were treated. All patients received a pre-phase, a first induction, with a second for those who did not achieve complete remission. And subsequently, they received 2 consolidation cycles, a late intensification, and a third consolidation, followed by a 2-year maintenance. Prophylactic central nervous system irradiation was included. Participants under 55 years of age were assigned to allogeneic stem cell transplant on the basis of conventional risk factors such as high presenting white count, adverse cytogenetics, and slow early response. The overall allogeneic transplant rate was 35%. After initial induction, patients were randomized to receive either standard dose cyclophosphamide or the more intensive cyclophosphamide regimen termed Hyper-C. Listeners should also be aware that patients with blasts expressing CD20 at greater than 20% participated in a rituximab randomization in which a significant benefit for rituximab was found. An advantage was apparent in the rituximab arm as published in the New England Journal of Medicine recently. The current report states that the two arms did not statistically significantly interact. What did the Hyper-C randomization analysis reveal? 723 patients, that was 92%, achieved complete remission. The complete remission rate was not significantly higher in the Hyper-C arm, which was 93.6% compared to 90.2% in the standard arm, and the p-value was 0.091. Now, more patients achieved complete remission in just one course of induction in the Hyper-C arm than the standard C arm, and this finding just reached statistical significance with a p-value of 0.048. However, neither event-free survival nor overall survival were higher in the Hyper-C arm, even after censoring an allograft. So, what makes this study interesting? Well, an important aspect of any clinical study of intensification of chemotherapy treatment in ALL is to shed light on any age limit for treatment tolerability and risk-benefit ratio. This study did not pre-plan any age-related subgroup analyses, which seems a little surprising, although it is important to recall the study was planned more than 13 years ago. Nonetheless, it is appropriate that post-hoc analyses by age were conducted, since by now we are even more acutely aware how closely age very clearly relates to outcome in ALL. Indeed, in this study, overall, age had a strong impact on survival outcomes. the authors report that increasing age continuously worsens survival. They mention that the strongest age cutoff was at 55 years. Within the paper, Figure 2b shows Kaplan-Meier event-free survival curves for 5 different age groups. The over 55s have a notable diminution in event-free survival compared to the other groups. Nonetheless, those aged 35 to 54 years also have a worse outcome than those aged 18 to 34 years. Of particular note here, the main contributor to the poor outcome in the over 55s was an 18.5% incidence of deaths during induction and a 25.5% death in remission. The poor tolerability of therapy was also underlined by a worse compliance with the prescribed therapy in patients aged 55 years or more, especially to asparaginase dosing. But there was no relationship between age and relapse risk. Against this background of no difference between the arms as a whole and worsening outcome with increasing age, the study had an unexpected subgroup finding. There was a lower hazard ratio of 0.51, a 95% confidence interval of 0.32 to 0.84 for event-free survival in favour of the Hyper-C arm in the 50 patients aged 55 years or more. There were 43 patients in the control arm, with a significant interaction test at p equals 0.029. The study was not planned or powered to detect such subgroup interactions, so is this a chance finding of limited clinical relevance, or is it possible for the reader to conclude that lack of tolerance of the increased intensity of the protocol overall inadvertently revealed a benefit associated with Hyper-C? For clinical practice involving an individual patient, I find it hard to make this call, especially since the Graal 2005 protocol limited allografting to patients younger than 55 years, which may also have impacted the outcome. Certainly, those already using the Hyper-CVAD protocol for patients over the age of 55 may well be advised to stick with it, rather than attempting to intensify cyclophosphamide within alternate non-Hyper-CVAD schedules. However, for those engaged in clinical trials involving patients of this age group, this is certainly a noteworthy finding which is due further investigation. The authors also conclude that the results of this study confirm the value of a so-called pediatric-derived approach to treat adults with Philadelphia-negative ALL. In this regard, my opinion differs a little from the authors' conclusions. It is undoubtedly true that, despite the very high treatment-related mortality, patients aged up to 55 years old had a considerably better survival than would have been predicted by comparison with the historical cohort from the author's prior LALA 94 study. So, in that sense, I completely agree with the authors that overall their intensified approach has shown benefit for patients. However, it is important to note that pediatric-inspired schedules are not one well-defined entity. Whilst the Graal 2005 protocol certainly incorporated many intensified elements compared to LALA 94, treatment was not stratified by minimal residual disease monitoring. Cranial irradiation was employed. Pegylated asparaginase, a typical component of pediatric schedules, was not used, and allogeneic bone marrow transplant was rather liberally allocated. These 4 elements would definitely not form part of a standard therapeutic approach in a pediatric population. Furthermore, there is only modest overlap with some of the even more intensive pediatric-inspired approaches currently being tested in the United States. In summary, this study is notable for having demonstrated a substantial improvement in outcome for those aged less than 55 years by intensifying therapy, and for further showing that adults over 55 cannot be successfully treated even a little bit like children. We've reached the limit of what intensified chemotherapy can achieve for our older adult patients. I urge the listeners to enroll all such patients into trials of novel agents wherever possible, as we urgently need to change our thinking and our approach on how best to help them.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.